Assalamu alaikum wa rahmatullahi wa barakatuh. I'm Professor Dr.Walaa Adel. I will talk to you about the second part of systemic hypertension lectures, and we will talk about the management of systemic hypertension. Our intended learning outcomes will be to recognize the rationale of management of patients with hypertension, to identify the cardiovascular risk factors, the silent target organ damage, and how to risk stratify hypertensive patients. Also, to set the appropriate treatment plan and the target blood pressure for each patient, to explain the recommended lifestyle modifications to hypertensive patients, to recognize the required patient education, and finally to describe the classes of antihypertensive drugs and their indications of use. Why should we treat hypertension? Because we want to reduce the adverse events. It is proved that reduction of blood pressure by 5 to 6 millimeter mercury decreases the risk of stroke by 40%, the coronary heart disease by 15 to 20%, the heart failure disease, progression of renal disease, and mortality from vascular diseases. So, the treatment has great benefit for high-risk patients. Our steps of management will start by to identify the patient risk first, then to identify if he has target organ damage, if it is silent or manifest, to set the appropriate treatment target, and to tailor the treatment plan, and how to start your patient's education. First, we will identify the patient risk by we will ask about if the patient has diabetes mellitus, if your patient is male more than 55 years old or female more than 65 years, if he has dyslipidemia, if he is a smoker, if he has obesity with a body mass index more than 30 kg per square meter, if there is microalbuminuria, metabolic syndrome, or there is family history of atherosclerotic cardiovascular disease in the first degree relatives. This table show how to risk stratify patients when we know the risk factors for each patient and if there is organ damage or diabetes or chronic kidney disease. According to the number of risk factors, we can risk stratify our patients. According to the presence of diabetes or not, also will help in risk stratification. The presence of chronic kidney disease and the presence of organ damage. All these factors are used in this table to risk stratify our patients. Our risk categories are low risk, moderate risk, and high risk. This table will be explained in details in the face-to-face mini lecture, inshallah. The risk profile for hypertensive patients, we can say that low-risk patient has no additional cardiac risk factors, has no organ damage, no associated atherosclerotic cardiovascular or renal disease. However, moderate risk patients, these patients who have 1 to 2 additional cardiovascular risk factors. On the other hand, high-risk patients have more than 3 risk factors or organ damage or diabetes mellitus or chronic kidney disease. Very high-risk patients are those category of patients who are having symptomatic established cardiovascular disease or renal failure. To identify the second part in risk stratification is to identify if there is target organ damage or not. The organs we are looking for are the heart, if the patient has left ventricular hypertrophy as diagnosed by the ECG criteria or the echo criteria, coronary heart disease, or heart failure. If the brain is damaged, we will ask about stroke, transient ischemic attacks. If the patient has chronic kidney disease or peripheral vascular disease or any degree of hypertensive retinopathy. So these are the organs we are looking for to exclude target organ damage. The third step is to set an appropriate treatment target for each patient. If the patient is non-elderly, our target number is less than 140 over 90 millimeter mercury. If the patient is elderly, our target will be higher a little. It will be less than 150 over 90 millimeter mercury. If the patient has chronic kidney disease with proteinuria or diabetes, the target will be lower than the non-elderly. It will be less than 130 over 85 millimeter mercury. This identifies the guidelines for treatment of hypertension, and it will be explained in details in the face-to-face session, mini lecture, but it shows you how the goals are set. The systolic blood pressure goal less than 140 for non-elderly, and for the elderly between 150 and 140, and we will revise this in the face-to-face sessions. Also, to complete the guidelines for management, this flow chart will be explained in the face-to-face session. The fourth step is to set the treatment plan. The treatment plan always will be started with a non-pharmacological treatment. Starting treatment is joined with or without drugs, but we should always start with non-pharmacological treatment. Why? Because this will reduce cardiovascular risk, and also this will reduce the dose and the number of drugs needed for controlling your blood pressure. The pharmacological treatment, we have more than one class of antihypertensive drugs. Can be summarized by the letters A, B, C, D plus others, and we will explain this in the next slide. The choice between classes is depending on the compelling indications and the contraindications for each class. Whether to choose between monotherapy or combination therapy according to your patient's situation. Interventional treatment for hypertension comes after the non-pharmacological and the pharmacological insufficient treatment, so we will go for interventional treatment as in cases for renal artery denervation. Surgical treatment as in cases of tumors present, such as pheochromocytoma, for example, by adenoma excision, and always follow up for hypertensive patients is mandatory. The non-pharmacological treatment, as we all know, it is depending on lifestyle modification. It's changing the behavior of the patient in his life, so that we will encourage weight reduction, intake of healthy diet. We will ask him to reduce or her to reduce the salt intake, encourage healthy diet, which is summarized as the DASH diet for hypertensive patients. It consists of low saturated fat or fat-free food. Control stress by techniques like relaxation exercises or meditations techniques. To encourage the patient to have regular exercise, to stop smoking, to reduce alcohol, and to try to do stress management. This table shows you how the effect of lifestyle modifications can reduce the systolic and the diastolic blood pressure by variable degrees. And it's worth to say that it is a cumulative effect. So if you are working on more than one item of lifestyle modification techniques, you will have cumulative effect, and the reduction in blood pressure, systolic and diastolic, will be more than if you reduced one item. Diet and weight control alone can reduce the systolic blood pressure by 6 millimeter mercury and the diastolic by 4.8, for example. Multiple interventions, relaxation therapies, physical activity, DASH diet, reduced alcohol intake, reduced salt and sodium intake, all can reduce the systolic and diastolic blood pressure in ranges between 3 to 6 millimeter mercury. Pharmacological treatment classes, we can classify them into first-line standard treatment and second-line drugs. We choose the antihypertensive drug according to certain factors, as we said before. How we choose the antihypertensive drug and how to monitor the drug therapy, we will talk about this in details. The first class is ACE inhibitors, or angiotensin converting enzyme inhibitors. These will work on the angiotensin conversion in renin-angiotensin system, and three main categories are established or well used in the market: the enalapril 20 mg per day, ramipril 5 to 10 mg per day, lisinopril 10 to 40 milligram per day. The angiotensin receptor blockers, these are proved to cause less cough side effects compared to the ACE inhibitors. For example, irbesartan and valsartan. Letter C for calcium channel antagonists, dihydropyridines and non-dihydropyridines. Dihydropyridines are useful for elderly patients like amlodipine and nifedipine. Non-dihydropyridine drugs like diltiazem and verapamil. The letter D goes for thiazide diuretics, and of course B for beta blockers. But in the recent guidelines, beta blockers are no longer used as first-line antihypertensive therapy, except in patients with other indications like angina. We use the last mentioned drugs, the ACE inhibitors, the ARBs, the calcium channel blockers, and the diuretics first, and lastly the beta blockers if there is other indications like ischemic heart disease. Metoprolol, ethinoprolol, bisoprolol, especially bisoprolol, is a good drug because it is a cardioselective beta blocker. Alpha and beta blockers like labetalol or carvedilol can be used also. Second line drugs are formed from other diuretics, central alpha-2 antagonists, peripheral sympatholytics, vasodilators. Start with other diuretics like loop diuretics, furosemide, torsemide, butanide, potassium-sparing diuretics, spironolactone, amiloride, central alpha-2 antagonists or central sympatholytics like alpha-methyl-dopa or clonidine, peripheral sympatholytics like reserpine and guanethidine, vasodilators, whether direct arterial vasodilators or alpha-1 adrenergic blockers like doxazosine or prazosin. The side effects of vasodilators is postural hypotension, fluid retention. Also, minoxidil increases facial hair, so it is not preferred for female patients. What are the factors influencing the choice between classes? What we call the compelling indications. This will depend on the patient age, the socioeconomic status of the patient, cardiovascular risk factors, comorbid conditions, associated cardiovascular diseases like ischemia or heart failure, and drug-drug interactions. For example, We can use alpha blocker for patients having benign prostatic hypertrophy. We can use ACE inhibitors for patients having heart failure, left ventricular dysfunction, post-myocardial infarction, or established coronary artery disease, patients with with type 1 diabetic nephropathy, and patients for prevention of secondary stroke. Also possible indications will be patients with chronic renal disease type 2 diabetic nephropathy. So ACE inhibitors are preferred for patients having diabetic nephropathy and patients having heart failure or left ventricular dysfunction. Angiotensin II angiotensin II receptor blockers are preferred for patients having intolerance to ACE inhibitors due to side effects like resistant cough, for example. But also it is preferred as ACE inhibitors in patients with diabetic nephropathy, hypertension, with left ventricular hypertrophy, or left ventricular dysfunction. Beta blockers are preferred for hypertensive patients with myocardial infarction, with angina, or with heart failure. Calcium channel blockers, dihydropyridine, as we said before, is preferred for hypertensive old patients or elderly patients, and also for patients with isolated systolic hypertension. Calcium channel blockers, the rate limiting or the non-dihydropyridine groups, are preferred for patients with angina. Possible indication for older patients. Thiazide diuretics or thiazide-like diuretics are preferred for elderly patients, for patients with isolated systolic hypertension, for heart failure patients, and for secondary stroke prevention. How to choose between antihypertensive drugs also includes the drug combination, whether we will choose monotherapy or more than one drug or combined therapy. Why we go for combination? We go for combination to be more effective, less side effects, and to have more patients compliance. Why? Because if you combine more than one class of drug, you will have more effect to decrease the resistant blood pressure or the very high blood pressure. And why less side effects? Because drug combination, you can give small doses of each drug, not to go for large doses of a single drug. That's why you have less side effects. And of course, you will decrease the number of tablets the patient is given per day, so you will have more patient compliance. This flow chart shows you how we go step by step in treatment of hypertension as an initial start with a hypertensive patient. First, we determine the age of the patient, less than 55 years or more than 55, or black person or African family origin of any age. If he is less than 55 years, we will start by ACE inhibitors, angiotensin II receptor or angiotensin II receptor blockers. Then, if not effective, we will go to step 2. We will combine ACE inhibitors with calcium channel blockers. If still not effective, we will go for step 3. We will add thiazide type diuretics. If still not effective and the blood pressure is still high above the target, as we said before, so this is called resistant hypertension. Resistant hypertension, if we have this, it will be explained later in different lecture, but we should consider further diuretic addition or adding alpha or beta blockers. Also consider seeking expert cardiologist for advice. If the age of the patient is above 55 years, or black person, or African Caribbean family, origin of any age, we will start by calcium channel blockers. Better to start with calcium channel blockers. Not effective, add step 2, add angiotensin converting enzyme or ARBs. If not effective, add diuretics, and the same if we have resistant hypertension. So this is how to start or to initiate therapy for a newly diagnosed patient with hypertension. A very important question: monitoring of drug therapy. Any patient given antihypertensive drug should be monitored. For how long? For a period up to 2 months may be required for antihypertensive drug to reach the maximum effect. So we are not expecting that the blood pressure will decrease on the spot if we give the drug. We have to give space or chance for the drug to start working and to have its maximal effect. Do not change the drug at short intervals. This is not helpful at all. You have to recheck the blood pressure of the patient at monthly interval till reaching the target for 2 successive visits, then recheck every 3 to 6 months. So at first, the frequency of rechecking is more than after establishing our target. Treatment and follow-up should continue indefinitely. There is no cure for hypertension. Hypertensive patients are not cured, and they have to know this. And they have to know that treatment should continue indefinitely. Gradual reduction of blood pressure is preferred for elderly patients. That's to say, take a time over 2 months to lower the blood pressure of the patient so that you will have less side effects for this fragile category of patients. Combination therapy is preferred than monotherapy for severe high-risk patients to achieve the target blood pressure at a period of 2 to 3 weeks. Patient education, the last but not the least. We have to learn the patient or to teach the patient that hypertension is a silent disease. It has no symptoms and no signs or minimal signs. And the treatment of hypertension, as we said, is a lifelong. Once started, it should not be interrupted or stopped for any cause. Drug treatment is not given on demand. It has to be given in a fixed intervals. You cannot stop the drug if your blood pressure comes controlled on treatment. You have to teach your patient that your blood pressure is controlled because you are taking the treatment. If you stop the treatment or delay it, your blood pressure will be elevated again. Regular follow-up and monitoring of blood pressure for 3 to 6 months is crucial after establishing the target. Lifestyle modification is an important component of the management. Antihypertensive drugs can lead to some side effects. Please be ready with your questions in the next face-to-face session. Thank you very much.